So how do we manage constipation with opioids? Well, if we have a look at the general approach towards constipation, it is a stepwise process so that we start with a bulk forming agent, and you notice that all these bulk forming agents have one thing in common, and that is that I can't pronounce them. And then if they're ineffective or poorly tolerated, then you add or substitute an osmotic laxative, such as macrogol, lactulose, or sorbitol. And then if they're ineffective or poorly tolerated, then you add or substitute a stimulant laxative, such as bisacodyl, docosahexaene senna, or maybe sodium picosulfate. So this is a stepwise process that we take. So the general approach towards patients who have constipation with opioids, though, is somewhat different. Firstly, constipation is very common and most of the agents take 2 to 3 days to start to work. So what we actually do is we actually take a prophylactic approach and use treatment up front. Now, bulk forming agents actually don't work and may actually make the constipation worse, so we don't use them. And that's probably a good thing because we can't pronounce them anyways. What we do start with is to put almost every patient on docosahexaene senna. So that's a stool softener and a promotility agent. And so that's at a dose of 1 to 2 tablets orally once at night or say twice a day. If that's ineffective or poorly tolerated, then you add or substitute an osmotic agent such as macrogol. What's important about this is that this is mixed and given with water. That's very important because a lot of patients who are on opioids or in palliative care are actually dehydrated with poor oral fluid intake. So if that's the case, then we tend not to use lactulose or sorbitol because the way they work is that they actually draw water into the bowel. If the patient has poor oral fluid intake, then in actual fact this can make the constipation more painful for the patient. The next step really depends very much on the specific issues the patient has. So for example, if they have a hard stool, consider adding docosahexaene 240 milligrams, for example, as a stool softener. Or if they have specific issues expelling a hard stool, then you can add a stimulant or use a local enema. So this is essentially the stepwise approach that we use. And if the patient has ongoing constipation and symptoms beyond this, then more specific treatment is required.